Okay, let's unpack this. Imagine a really sudden, forceful impact. The kind that doesn't just, cause a bruise or a cut, but potentially sends energy right through the bone, deep, deep into the base of the skull.
Yeah, a significant mechanism.
Exactly. And today, you have brought us your revision notes asking us to take a deep dive, specifically into basal skull fractures. Our mission is pretty clear. We're going to go through these notes you've provided, pull out all the absolutely essential high-yield stuff, make it clear, make it memorable.
So it clicks when you need it.
Right. So when you need to recall this, it's right there. We'll cover everything your notes mention, from the basic definition right through to, well, the long-term effects.
That's right. It looks like a really comprehensive set of notes here. We've got definitions, causes, etiology, risk factors, the pathophysiology, what's actually happening.
What it looks like clinically.
Yeah. Clinical features, differentials, how to tell it apart from other things a bit on epidemiology, investigations, management, of course, and then prognosis and complications. We'll stick strictly to what's in your material here.
Perfect. Okay, so let's jump right in. The absolute basics. Your notes start with defining basal skull fractures. What exactly are we talking about?
Well, simply put, it's a fracture specifically at the base of the skull. Your notes are clear this can involve the anterior, middle, or posterior cranial fossa.
Okay, so not just across the dome, but that really complex, sort of uneven bit the brain sits on.
Precisely. And the notes list the bones that might be involved. Ethmoid, sphenoid, occipital, parts of the frontal and temporal bones too. All those components forming that skull base.
And how do these usually happen? It sounds like it takes quite a bit of force.
Oh, absolutely. High energy events. The notes stress severe head injuries, often linked to major trauma involving the head and face.
Like a direct impact.
Yeah, direct impact is a big one. Motor vehicle accidents are common, serious falls, assaults as well.
Which, I guess, explains why your notes mention they're seen more often in younger people doing, well, riskier things.
It fits, yeah. And your notes give us a really crucial early heads up. Many can be managed conservatively without surgery.
Okay.
But the real worry, the thing you need to be alert for, is the potential for complications. Your notes flag things like intracranial injury, CSF leaks, meningitis, cranial nerve problems. These are flagged right at the start as key things to have on your radar.
Right. Understanding the potential is vital from the outset. Okay, let's dig a bit deeper into how they happen. The etiology, the mechanism. Your notes point to trauma, high energy impacts.
That's the main driver, yeah. MVAs, falls from height, serious assaults, those are the classic scenarios. But what's interesting, and your notes highlight this, is it's not always a direct blow to the base.
Ah, okay.
The force can actually be transmitted from surrounding areas, like severe facial trauma or even injuries traveling up from the cervical spine.
Wow, okay. So a really hard hit to the jaw, say, could theoretically transmit force down and fracture the base. That makes a lot of sense, thinking about how it's all connected.
It does. And here's a really, really crucial point from your notes. Definitely high yield for revision. These fractures almost never happen in isolation.
Okay.
They are very frequently associated with underlying brain injury. And critically, they should always make you think about potential cervical spine injury. Always. C-spine clearance is essential.
Got it. BSF means think C-spine. Sign. That's a key link. All right, who's most at risk? The notes seem to break this down.
Yeah, they categorize it quite clearly. First, just people engaging in activities with a higher inherent risk of, significant trauma.
Like contact sports?
Contact sports, yeah, or certain jobs like construction.
And then there are factors that just increase the risk of severe head trauma in general.
Exactly, which then increases the chance of a BSF if an injury does happen. Your notes mention things like not using protective gear helmets, for instance. Impairment from alcohol or drugs, generally engaging in behaviors that just make serious accidents more likely. It helps identify who might be more vulnerable if trauma occurs.
Okay, we know what they are, how they happen, who's at risk. Now, here's where it gets really interesting, I think. The pathophysiology. What's actually going on inside when the base breaks, and why does that lead to those specific signs?
Right. The core issue is obviously the break in the bone, the disruption of the skull base, but the why behind the signs comes down to what's right next door.
The adjacent structures.
Exactly. The notes explain the fracture damages or disrupts these vital neighbors. We're talking the brain itself, the cranial nerves passing through little holes or foramina in the base, major blood vessels, and the meninges, those protective layers covering the brain.
So if the fracture tears the meninges, is that where the CSF leak comes from?
Precisely. Your notes make that link directly. Damage the meninges, you breach the barrier, and CSF can leak out. And because the fracture often extends into the sinuses or the ear structures, it leaks out the nose or ears.
Okay, that makes sense. CSF rhinorrhoea, CSF otorrhoea.
Exactly. And the bruising. Raccoon eyes, Battle sign.
Yeah.
That's bleeding from the fracture site itself, tracking along the tissue plans under the skin. It's not just a surface bruise. It signals that deeper bleeding linked to the fracture pattern.
Got it. And severe cases.
Your notes state that in severe cases, the fracture can extend right into the cranial cavity, causing direct brain injury or significant bleeding inside the skull, like an epidural or subdural hematoma, raising intracranial pressure.
Understanding that chain reaction bone break damages adjacent stuff like meninges, nerves, vessels, really helps cement those clinical signs for revision. Speaking of which, what are the key things we're looking for clinically? What might the patient say, or what do we see?
Well, the presentation can vary quite a bit, depends on where the fracture is, how bad it is, what else is injured. But your notes list several key things to look for.
The classic visual ones we just mentioned, the bruising around the eyes, raccoon eyes, and behind the ear, battle sign.
Those are definitely high-yield visual cues, yeah. But the notes also list signs directly from the meningeal tear we talked about. CSF leaking from the ear, CSF otorrhoea, or the nose, CSF rhinorrhoea.
And just plain blood from the ear, otorrhoea.
Yes, that too. And then there are symptoms that point towards cranial nerve damage because those nerves run right through the fracture zone potentially.
Okay.
Things like hearing loss, facial weakness, maybe double vision, difficulty swallowing. And altered consciousness is also listed, which usually points towards an associated brain injury.
Those CSF leak signs, they feel particularly important to remember.
They really are. Like your notes imply, they mean there's a direct connection between the sterile inside of the skull and the outside world. Big implications for infection risk.
Okay, so we see some of these signs, but head trauma can cause lots of different injuries. How do we specifically pinpoint a basal skull fracture versus something else? The notes mention differential diagnosis.
Right, and this is where investigations really come into play. The clinical picture raises suspicion, obviously, but imaging is how you differentiate definitively.
CT scan, is that the main tool?
Absolutely. Your notes are very clear. The specific pattern, the location of the fracture lines you see on a CT scan, that's crucial for telling a BSF apart from other head or facial fractures.
And does the combination of signs help as well?
Oh yes, definitely. That unique cluster we discuss, especially if you have a CSF leak, specific nerve problems, maybe bleeding inside the head seen on CT, that whole picture points much more strongly to BSF than, say, just a concussion or an isolated facial bone fracture.
What else should be on the list of possibilities, things to rule out after head trauma?
Your notes mention concussion, other types of facial fractures, and brain contusion as key differentials to consider. Distinguishing between them is obviously critical for the right management.
Okay, let's shift slightly to epidemiology. How common are these? Your notes touch on this, mentioning the UK specifically.
Yeah, your notes state that specific UK data on how common basal skull fractures are isn't readily available.
Okay, so no hard numbers in this source.
Correct. But the notes do say they're generally considered less common than other types of skull fractures, like linear fractures of the vault. The incidence really depends on the population, those risk factors we discussed, regional trauma patterns, things like that. It's a brief point reflecting the info available.
Understood. So, investigations. How do we actually confirm it and see the full picture?
Well, suspicion starts clinically, the mechanism, the signs. But confirmation, as we said, needs imaging. Your notes are unequivocal here. CT scan is the primary tool.
Go-to for confirmation.
Absolutely. The notes emphasize CT shows you the fracture location, the extent, and crucially, any associated injuries, brain trauma, intracranial bleeds. It's vital for the whole picture.
What about confirming those CSF leaks if you suspect one? If you see clear fluid from the nose or ear?
Good question. The notes mention using nasal endoscopy or otoscopy, basically looking directly with a scope to try and see the source of a leak or examine the structures.
And proving it is CSF.
Yes, this is a specific high-yield point from your notes. Testing the fluid for beta-2 transferrin. That protein is pretty specific to CSF.
Okay.
And for a really detailed look, maybe at soft tissues or blood vessels, if there's concern about injury there, your notes mention specialized tests like MRI or angiography might be needed sometimes.
So CT first for bone and acute bleeds, endoscopy, otoscopy to look for leaks, beta-2 transferrin to confirm CSF, and MRAngio for more detailed soft tissue or vascular assessment.
That's a good summary of what your notes suggest.
Right. We've found the injury, and the big one, Management. How do we actually manage these based on the notes?
Okay, the notes lay out the main goals. First, stabilize the patient ABCs, as always, in trauma. Then, prevent further injury and manage or prevent those complications we've talked about.
Sounds like a team effort.
Definitely. Your notes highlight it's a multidisciplinary approach. You'll likely involve neurosurgeons, ENT surgeons, maybe maxillofacial surgeons, depending on what's broken and what associated injuries there are.
And the treatment plan itself.
Highly tailored.
Yeah.
Depends on how severe the fracture is, where it is, what else is injured, the patient's overall state.
Does everyone need an operation?
No, actually. Yeah. Your notes state conservative management is common, especially for stable fractures. Meaning close observation in hospital, good pain management, and just watching very carefully for any signs of complications developing. And this is important. Your notes specify that even stable, non-displaced fractures that don't need surgery still absolutely require hospital admission and monitoring. You can't just send them home.
Right. Observation is active management here, and it needs to be inpatient. When is surgery needed then?
Surgery is reserved for the more significant problems. Your notes list things like significantly displaced fractures, any intracranial bleeding that needs draining, cranial nerve injuries that might benefit from decompression surgery, or a persistent CSF leak that just isn't stopping on its own because of that meningitis risk. Surgical options mentioned include decompression or directly repairing the dural tear causing the CSF leak. And supportive care, good pain relief, anti-sickness meds is key too.
Your notes have some really specific, almost like warning points in the management section. These feel incredibly high yield.
They are. Absolutely critical details flagged in your source. First one, anticoagulants. If the patient is on blood thinners, your notes warn you need very close monitoring for any neurological decline. The bleeding risk is obviously much higher.
Right, makes sense. And antibiotics. This one seems counterintuitive sometimes.
It's a major point from your notes and often tested. There is NEO evidence to support giving prophylactic antibiotics just to prevent meningitis after a basal skull fracture.
Wow. Really? Even with a CSF leak?
Even with a potential CSF leak. Your notes state routine antibiotics are not recommended just for the fracture itself. That's a key takeaway.
Okay, that's vital to remember. No routine prophylactic antibiotics. What about feeding tubes?
Another absolute contraindication highlighted in your notes, nasogastric tubes, NGTs, are a definite NO.
Why is that?
The concern, and your notes are clear on this, is the tube could potentially pass through the fracture line at the base of the skull and end up inside the cranial cavity. Catastrophic.
Right, so what do you use?
Orogastric tubes, OGTs, pass through the mouth instead. That's what the notes specify.
Okay, so memory joggers, check anticoagulant status,
Yeah.
NO, routine prophylactic antibiotics, and OGT only, never NGT. Those are huge safety points.
Exactly. And your notes also, quite rightly, put all this specific BSF management within the bigger picture of initial trauma care, starting with airway, breathing, circulation, and always securing the C-spine first. That fundamental assessment comes before anything else.
Okay. We've covered assessment, management. If we connect this now to the bigger picture, what's the outlook, the prognosis, and what are the potential long-term problems, the complications?
Prognosis. Well, your notes say it's highly variable. It depends a lot on how bad the fracture itself is, but especially on any associated injuries.
Particularly brain injury.
Particularly the extent of any associated brain injury. That often dictates the long-term outcome more than the bone injury itself. Your notes suggest that isolated fractures without major intracranial problems tend to have a more favorable outlook if they get prompt, appropriate management.
So timely care matters hugely.
Significantly. That and the patient's overall health baseline.
Okay. Now, the complications section in your notes, it's quite a list. These are the things we worry about down the line.
Yes, these are the potential acute and chronic issues directly linked to the fracture and the damage around it. We've mentioned infections already, meningitis or osteomyelitis, bone infection, because that protective barrier is breached.
And the cranial nerve damage we talked about, can that be permanent?
It can, yes. Your notes list persistent cranial nerve deficits, ongoing facial weakness, double vision, hearing loss, swallowing problems, intracranial bleeding, like subdural or epidural hematomas, needing treatment is also listed as a complication.
What about physical changes?
If the facial bones are badly involved, your notes mention facial deformities as a possible outcome, sometimes needing later reconstructive surgery.
And cognitive effects. This seems important, but maybe less obvious initially.
Extremely important. Your notes list cognitive impairment. Memory problems, attention issues, changes in behavior. These often stem from the associated brain injury, not just the fracture.
Hearing loss, too.
Yes, listed as a complication, temporary or permanent, might need intervention. Persistent CSF leak is also a complication in its own right, carries that ongoing meningitis risk, might need surgical repair eventually.
And one more thing on the list. Seizures.
Yes, post-traumatic epilepsy. Your notes mention an increased risk, potentially needing long-term anti-epileptic medication. So that whole list really underlines why even fractures that seem stable need very careful watching. The potential for serious problems, both early and late, is definitely there.
So what does this all mean? We've basically walked through your revision notes on basal skull fractures, haven't we? We've defined them, looked at how these big impacts cause them, who's vulnerable.
The underlying damage, the pathophysiology.
The key signs you absolutely have to recognize: raccoon eyes, battle sign, those CSF leaks especially. How we confirm it, mainly with CT.
Right, and the really critical management points like no prophylactic antibiotics routinely and no NGTs.
And then the range of outcomes and those potential long-term complications.
We've really tried to pull out the high-yield information from your notes, frame it in a way that hopefully makes it stick for your revision. Understanding BSF isn't just about spotting a broken bone. It's appreciating the anatomy, the potential for serious damage to nearby structures, and that whole cascade of possible issues.
Yeah, and I think these notes really show us something important. While the initial focus might be on the fracture itself, perhaps the most significant, the most lasting impacts might be less visible.
Like the cognitive changes.
Exactly. The potential for cognitive issues or neurological problems, epilepsy, things that can affect someone years later. It makes you think about severe head trauma, not just as that moment of injury, but as a potential challenge stretching way into the future.
A really good point.
Well, thank you so much for bringing your notes to us for this deep dive. We really hope tackling them together like this has been helpful for you.
Absolutely.
And if you are looking for more resources as you revise, definitely check out MSRA.com. They've got comprehensive materials.
Yeah.
And also freemsra.com for some excellent free resources, too.
We wish you all the best with your revision efforts.
It's been a really insightful look at these injuries. Okay, that's all for this deep dive.